So good afternoon, everyone. Thank you for joining us for our Romano clinical rounds. I'm Sue DiGiovanni, the Vice Chair of Clinical Services. Before we get started, just a couple of housekeeping items. So for those who are attending virtually, if you have any questions that you would like to ask, we can address those at the end of the presentation. If you would just enter those into the Q&A, and I will review those at the end. For those present here, if you have any questions, if you would just ask at the end, and we have some extra microphones and we can go around so you can ask your question. Also, at the end of this presentation, you will see a QR code that you can then scan if you're present here to be sent to a link for the survey so that you receive CME credit. And for those who are attending virtually, and for anyone here as well, there will be an email that will be sent out in a day or two where you can, again, get a link to a survey so that you can receive your CME credit. So we'll get started. I'm going to introduce Courtney Blackwood, who will be introducing the other presenters today. So Courtney is currently our Nursing Director of Behavioral Health, and she has worked in nursing for over 15 years, and in the last 10 years has been in leadership positions. She received her Bachelor of Science in Nursing from St. John Fisher, and then her Master of Science in Healthcare Leadership and Administration from the University of Rochester in 2017. She has served providing oversight to operations, planning, and advising of nursing care within all divisions of our department, and currently also serves as the clinical advisor to the University of Rochester School of Nursing. She has presented presentations nationally on clinical simulation, retention strategies, as well as staffing implementation models. She also serves as co-chair of the hospital's Diversity, Equity, and Inclusion Committee. And most recently, she has been the recipient of the 2023 Rochester Business Journal Healthcare Hero Management Award. So as you can tell, we are very, very fortunate that she joined us. And she came right around the time of the COVID pandemic. So quite an introduction to our department. So we have been very, very lucky to have her working with us. And Courtney, I'll hand it over to you.
Hi, everyone. I am going to introduce Heather O'Brien and Nancy Bowllan. We'll start with Heather. Heather joined the University of Rochester as a staff nurse back in 1990. She worked here when child and adolescent was on our old 19200 space in 1993. She received her master's from the University of Rochester and worked in child psychiatry as an advanced practice nurse for many years. Heather has been a service educator in our department for over 20 years. She is ANCC board certified in nursing professional development. She participates, as many of you know, in all of our quality, safety, and educational groups across the hospital. All of our onboarding and education of new nurses Heather has been a part of. Heather also worked as an adjunct clinical instructor at both the University of Rochester and St. John Fisher University. Nancy Bowllan has been a psychiatric nurse for the past 43 years. Her first position was on the behavioral therapy unit that is within our department of psychiatry. Nancy received her master's at the University of Rochester in 1991 and worked as a clinical resource nurse. She's worked inpatient, outpatient, residential treatment, and in school-based health clinic as both a therapist and educator. Nancy has been part of the St. John Fisher family for 18 years, where she received her doctorate in executive leadership in education. So today I am going to be talking about, or the three of us will talk about, safety and self-reflective practices from an interprofessional perspective and looking at educational initiatives that have been led by psychiatric nursing. Again, I'm Courtney Blackwood, Nancy Bowllan, and Heather O'Brien. We will all take pieces of this presentation. our learning objectives. So by the end of this education, we would like everyone to identify 2 components of each of our educational initiatives and the application of safety and self-reflective practice. Also having an awareness of our own self-reflective practice and how it can be incorporated. I have no financial relationships. I have nothing to disclose. So we're going to begin. So I'd like to start with these. The next hour, we're going to talk about 4 psychiatric nursing-led initiatives that are very broad-based, and we're going to be talking kind of fast because they're quite large, and we only have an hour to do it. But really, when we're thinking about it, we have 2 umbrellas that we're looking at education through. There's a safety umbrella and also a self-reflective practice umbrella that really we have structured all of our educational initiatives through. The 4 that we will be talking about today are 1, our simulation, high fidelity simulation experience that we completed within CPEP. Our Safe Words model of practice that hopefully most of you are familiar with, but we'll talk about what that looked like, how many nurses went through the training, what the impact has been on both patients and staff from a safety perspective. Then we will move into our psychiatric nurse residency program, which we did not have prior to 2021, and we will close out with our adaptive leadership series that we just recently completed. So as Dr. Giovanni mentioned, I came into this department during the pandemic at the end of 2020. And looking at our department, really what we started with was an overall needs assessment. You know, what's important to our department? What are we looking at? What is everybody talking about? What's meaningful? What's our patient care like? And these are just some of the things that I began looking when I started here, looking at our safety surveys, looking at our Press Ganey surveys. How does staff feel about their job? Do they feel safe at work? What are our restraint numbers and seclusion numbers? What's our nursing team like? So these are all just different pieces through a needs assessment. Now, I'm going to start with our simulation experience and give you a little bit of a background in how this started and what the event was that really precipitated the education that went into this experience for our staff. So I'm going to do a brief overview and just a background of the project that really brought our education, needed education to fruition. So at the end of October of 2020, we had an incident in CPEP that a 30-year-old African-American male, he was displaying some dysregulated behaviors. We called DPS for additional support. At that time, the patient had been barricaded in a room. Pepper gel was deployed to gain access into the room. So it was a very traumatic event for all involved, especially the patient. So as we always do, we did a very thorough RCA. And in that RCA, we found that, you know, things went wrong that did not have to go wrong. And we realized that we had a huge gap in practice and in the care that we were providing and in our policies. And we wanted to review everything. So really, there were 4 key components that came out of this. And the first was, we really need to look at how we communicate, not just with DPS officers, but how do we communicate with each other, and what is everybody's role during a behavioral health crisis? The second was, what is our response when a patient is dysregulating? So how are we talking to patients? How are we managing patients? And what role is everyone playing during a crisis? Third, it was looking at our policies, and we realized that the policies that we have are not, one, we're not following our policies as seamless as they should, and 2, our policies needed some adjustment because the language wasn't matching our clinical practice and our clinical practice wasn't matching the language. So we had to really dive into our policies and make some changes. And the fourth was that really we need to think about the training that we're doing, because what came out of this is that nurses are trained over here and residents are trained over here and social workers get a little bit of this, and our crisis specialists are doing something totally different. And we realized that's not how we should be training. We really want to look at interdisciplinary training and how that can be applied to our department. So that's a little bit of a background on where this piece of the project came from. And we started with our data. So what's our data showing? We chose 4 months before. So if you look at this data, this is specific to CPAP. This is looking at March through June. And you can see the number of restraints that happen in that environment over 4 months, which is high. And what you can also see is that our staff injury is very high, and this is varying levels of injury, but what we do know is that we really need to protect not only our patients, but all of our staff and drive these numbers down. So we put together this team, right? We said, okay, we need to come together as a group, and it has to be interdisciplinary, and we have to have buy-in from all disciplines to really make this work. So I was the team leader. I had nursing representatives, physician representatives, the Department of Public Safety, both their assistant director and patrol supervisor was part of these meetings. And really we met every 2 weeks for an hour to an hour and a half to figure out what do we need to do, what do we need to do different, and what's everyone's stake in this, including all of our patients. Christy Stockwell was involved, who's our program administrator in CPAP. We involved social work, our crisis specialists, and then we brought in consultants because we knew we needed help. We knew that we wanted a debriefing component to this education. At that time, we weren't sure exactly where we wanted it to be, how we wanted to implement that, but we knew we wanted space for all of our faculty and staff to feel safe, to talk about how the training went. So we brought in Telva Olivares, Carly Goff, and Sephora Rosenberg to help us through that. And Wendy Cross, who everyone knows across the department, was really instrumental in bringing this project forth. So this is just a picture of some of our task force team members. It's not an all-inclusive picture, but it just highlights that there was multiple disciplines that participated in this education. So when we came together as a group, what we did is we said, okay, what do we want? What's our objective? How do we want this to go? What do we want this to look like? What's our plan? So this came over some time, but in the end, we said, okay, this is what we want. We need to develop the content, and we need a plan for implementing structured interprofessional training sessions that include high fidelity simulation scenarios with agitated patients. And I'd like to highlight that culturally sensitive approach piece. That was really important to us because we know there's a lot of racial and cultural considerations that we wanted to weave into all of this education. We knew we wanted it to be evidence-based and that we needed a space for a reflective debriefing. Now, I came from the medical side, and we do a lot of simulation training on that side. And as we were doing research, looking at high fidelity simulation in psychiatry, there's a lot of simulation from doctor to doctor, nurse to nurse, things like that. But there wasn't a lot of research on interprofessional simulation in the Department of Psychiatry. And what we really wanted our participants to walk away with was how do they learn both clinical and non-clinical skills such as leadership, interprofessionalism, communication, teamwork. And this type of training we knew was ideal for emergency psychiatry. So we looked at the experiential framework, and that's what we decided, that's what we landed on because it makes the most sense for simulation training, but we used David Kolb's experiential learning cycle as our framework for this. So the 4 key points of this simulation really that we wanted to focus on was 1, communication. We knew that communication breaks down during crisis, and how do we communicate better with each other? Teamwork. We saw that there were many gaps in teamworks, and really we just weren't speaking or working well with each other during crisis. And interdisciplinary collaboration across all of the disciplines. How do we strengthen that during crisis? And really looking at what is everybody coming to the table with? Because nursing education looks very different than resident education. That looks very different than social work education. And then we put everybody in a crisis and we expect them to work well together. And it doesn't always go as planned. So really for the teamwork component, we looked at team steps, and what we found is about half of our participants had an awareness of what team steps was, and half of them didn't. So that was really the premise for bringing everyone together on how do we collaborate and work together as a team. So team steps was part of our strategy and pre-work that we had our participants complete prior to engaging in the simulation training. We based our de-escalation strategies and violence mitigation strategies from CPI, which is the Crisis Prevention Institute. All of that work had to be completed by all of our disciplines prior to engaging in the education. So everyone was coming with the same knowledge base. And then again, racial and cultural considerations, recognizing that the population of patients that we're caring for throughout this institution doesn't necessarily match the population of staff and faculty caring for these patients. So what does that look like, and how do we incorporate some of that into what we do? Our learning outcomes for all of our participants really was around, all right, how are we going to talk to each other during a crisis? And again, the pre-work on self-awareness, we had a questionnaire that was completed pre and post. We had a team steps, teamwork attitude questionnaire that was completed pre and post. And all of our sessions with our agitated patient was, they were video recorded. So there was a lot of direct observation that could be reviewed. How we work with each other, what our interprofessional teamwork looked like during a crisis, and how are we going to evaluate that? Again, direct observation, pre and post survey scales were really important, and then incorporating CPI through our third outcome, which is looking at violence mitigation and de-escalation techniques. So did they complete that CPI work prior to coming? And we introduced another scale, which Heather is going to talk to you about a little bit more next, but it's confidence in coping with an aggressive patient. And what we found is that varying levels of disciplines felt different levels of confidence in managing a patient that was de-escalating. But everyone that went through the training had the same, they answered the pre and post scale. So it was just really interesting, and we'll go over some of those results towards the end. And then at the end, we wanted a safe space where we were able to engage in self-reflective, in our own self-reflection in managing the crisis with our highly trained actors, and looking at cultural and racial considerations and bringing up those difficult questions that a lot of times people are uncomfortable answering. But this was really important to us to make sure that that awareness was present, and we gave people the space to do that. So next, Heather's going to go over a little bit more of the overall structure of the project and how it started.
Thanks, Courtney. So I apologize ahead of time because I'm going to be, condensing a 2-hour talk into a few minutes here. I just wanted to show this map, or this project map, because, and I know that you guys can't read it, but it just demonstrates the amount of work that went into this project, the multidiscipline work that happened in our task force group, and the months that it took to actually have this simulation come to fruition. Some of the details, we had 202 staff that we needed to move through this simulation, and we actually got 171 staff to participate. So that was pretty good, considering it was over the summer and we had lots of vacations and during the pandemic. So of course, I want to start with Wendy Cross. She was integral to this project. Many of you know her. She has lots of experience with simulation, but neither of us had any experience with group simulation. And so we spent a lot of time talking about how are we going to pull this off? How are we going to use the space that we have most effectively to create this group simulation? And also, budget. We had to think finances and figure out how we were going to pay for the actors and move through this project. I want to highlight, as Courtney mentioned, there is not a lot of articles out there about group simulation for multidiscipline psychiatry staff using standardized patients. We found nothing. These two came the closest, but both of them did not use standardized patients. They used role playing with staff. So the people taking place in the simulation already knew the people who were playing the patients. So the one on the left was a nursing textbook where they talk about safety and using simulation, and that was with nursing unlicensed assistive personnel. And then the one on the right is medical staff in a medical ED training to do a group response to a behavioral emergency. So That's what we were able to find. Of course, we have an extensive other list of literature. If you're interested, we can share that with you. Just some of the next steps, we had to, in working with Wendy, identify standardized patients that work here at the hospital that are actually interested in participating in our simulation. This was unlike anything they have done before. And so we were going to be asking them to become agitated, aggressive, psychotic, and that wasn't anything that they had experience with. So we spent a lot of time training them, working with them, blocking the space. I mean, just like as if you're creating some type of movie or play, we had to move them through the space and teach them how to do all the responses. We did the pre-learning, Courtney mentioned that. I just want to show the space that we use. So some of you may be familiar with the basement in psychiatry. That is where the sim room currently, or was set up at the time. You can see that we have a sim room, we have a production room, and down at the bottom you can see the observation room. So we were moving staff throughout this whole space. The facilitator coordinated all the staff movement throughout the simulation, and also communicated between the 3 different rooms and also with the standardized patient actors. The debrief instructor sat in the production room and controlled the simulation, when to start and stop it. And then the observation room instructor was supportive staff in the observation room, which I'll explain in a second. Here's a picture of the space. You can see that we mocked up the hallway as the CPAP nursing station. So all of the equipment and comfort items or things that staff might utilize to calm a patient down were available to them. This is the actual simulation room. We took pictures in a real CPAP and created what would be the view of patients looking into the nursing station in the waiting room. We also mocked up some fake patients because we could only have so many standardized actors. This is an example of the day. So we had, each session lasted 2.5 hours. We did 2 sessions per week over the summer. We ran 2 separate individual simulation exercises in 1 session, and we could accommodate up to 14 staff per session. So we split the staff group in 2, and the first group went through the simulation, and then we switched groups, and the second group went through. You can see there in the beginning, when they arrived, they completed the surveys. We spent a few minutes doing an orientation to the space and to the situation and to the simulation. Then they started the simulation. The second group was watching in the observation room. And when we switched, or when the simulation ended, the standardized patient left the area. They debrief themselves and write a few notes down, and then come back and give feedback to the group. They're giving feedback about the experience, how they experienced their interventions as a patient. And then we switched. The TV was turned off during the feedback, so the second group did not see the feedback to the first group. And then you can see after we switched, down at the bottom, we spent 45 minutes on the debriefing, and we asked them at the end to also complete the confidence in managing aggression scale, and then the evaluation of the educational experience. What was it like for you to participate in a simulation to prepare yourself to de-escalate patients? We had different tools that we use. One of the things we gave staff was some information on the patient before they entered the sim room. Here's some more pictures. This was our production room. This was the observation room where one of the groups would be watching the first group complete the sim. This is a close-up of the feedback session where the standardized patient is giving feedback to our pilot group. So we ran a pilot a few times to help the patients or the standardized patients finish their training. Here's a picture of all of our debriefing instructors. As Courtney had mentioned, we spent time training them. Debriefing is as important, if not more important, to the simulation exercise. We really wanted to give staff a safe space to be able to process. And we paid attention to the 3 phases. So we utilized different evidence-based articles and curriculum to help our staff debrief the situation. Here are examples again of the assessment tools. So one is the teamwork perception questionnaire, and the other is the coping with patient aggression instrument. So some of our data you can see here, this is the confidence in coping with patient aggression. We had a pretty good response. 141 people completed it before the SIM and after the SIM. And you can see we had a high reliability. And those were some of the questions that they had to answer. For the team steps, we did not get as great a feedback or response. So the team steps was done pre-SIM and then 3 months after. So we were sending emails hoping that people would complete the red cap survey. So that really didn't give us any statistical significance, or, people really were not completing it and commenting on their teamwork at that point. And then this is some of the educational feedback we got. It was a Likert scale. We took the percentages from agree and strongly agree, and people really did enjoy and or experience the simulation as helpful. And you can see the one that the briefing provided a safe opportunity to further explore my thoughts and feelings. People really responded to the debriefing session. And then here's our restraint and seclusion data. As Courtney mentioned, she showed some of the 4 months prior. You can see between the red stars, that was during our simulation education session in the summer. And then you can see post simulation training. And we had a 35% reduction in restraints and a 52% reduction in injuries. More thanks to Patrick Walsh for doing the data analysis, and then Steve Fasone and the AV Tech group for really helping us get through this whole project. I'm going to turn it over to Nancy.
Thank you. All right, Clickaroonie. Hello, everybody. I'm going to talk for just a few minutes about the Safe Wards model and also about the Psychiatric Mental Health Nursing Residency Program. The Safe Ward model originated in the United Kingdom. The main developer was Len Bowers, who is a psychiatric nurse. And the focus was on literature review, developing the model, and then researching it. So the team did an extensive review of the literature, followed by developing that model, and then they provided a randomized control trial, 31 units, which represented adequate power with significant results. And I think this is important because this is a really essential goal that we're working to, which is reducing restraints, reducing seclusion, and improving our de-escalation and crisis management. So conflict reduced by 14.6%, and close to a almost 25% reduction in containment measures, which would reflect seclusion and restraints. The key aims of Safe Wards is a much more proactive, engaged, and preventative response. We worked with our staff in training around exploring the relationship between conflict and the potential for use of restrictive interventions. A really important piece of this was focusing on milieu, engaging with patients, being collaborative, being patient-centered, and available. The program also incorporates 10 individual interventions to improve staff self-reflective practice, early interventions, and de-escalation strategies, with the goal to promote safety and patient-staff relationships. So these are some of the foundational concepts. They first identified 6 distinct domains that we need to think about as we are engaging with our patients. One is the patient community. What is the milieu like? How are patients engaging with one another? What are the stresses? What are the potential trauma that they might be experiencing? Individual patient characteristics. So that could be the acute episode of their psychiatric illness. It could include personality traits. So we need to be considering those things, as well as their previous hospital experiences. Regulatory framework, especially on inpatient unit, is considering status, It's considering, for instance, the use of rivers and potentially a court order for medication against their will. Staff team, that's another dimension that specifically looks at how are the staff members working together? What is the communication like? What is the crisis management skills? How do you communicate between nursing, the doctor, social work, activities therapist, and crisis specialist? The physical environment is another one. How does the units look? Well, we know some of them aren't looking that great. But, and how can we improve opportunities for patients to get together, providing a clean, respectful environment? And the last one is consideration of outside hospital elements. Patients often receive phone calls that are very, very distressing. Patients have been delivered divorce papers. They have had family members die while they're in the hospital, and that's just to name a few. So all of these dimensions are really important to think about as we work to develop our responses to patient and our treatment planning. The second component of this model is specifically looking at what is called flashpoints. Consider that like triggers, right? It's basically what are the individual triggers for a patient that might result in increased emotional distress, increased potential for agitation, and how to respond early. So examples of these interventions, and by the way, we initially piloted on 29200 and 39000. Those are the two acute adult inpatient units and had the most needs. So we really wanted to first initiate it there. So with them, we developed a poster which was hung out on the unit at various public areas that identified very specific, mutual, clear expectations, how we're going to work together, how we're going to respect each other, how we're going to maintain a safe environment. So there were approximately 10 individual expectations that were posted. Another intervention, which I think is really important, is the bad news mitigation. And that requires staff across all disciplines to be aware of what might be potential bad news or stressors a patient will experience while they're in the hospital, and how can we intervene more earlier to provide the support, because we know they're going to get emotionally distressed in that situation. Calm down methods was another important component, and that is basically a huge cabinet of a variety of therapeutic items that we offer to patients as they're becoming more emotionally distressed or agitated. A lot of different ranges. It could be like those poppers, which are these plastic, distracting kind of activities. It could be therapeutic drawing, artwork. We've also more recently included headphones. And it has been amazing, the response that patients have experienced by having access to these headphones to listen to music. So that's another example. Soft words is a process that was established through Safe Wards that helps staff to think about how we approach patients when they're distressed or agitated, and how we can respectfully and collaboratively set some limits. Something like, stop doing that is not going to work. So that's another important aspect. Talk down methods is basically a 3-step process of de-escalation, basically clarifying what the patient's concern is, what's distressing with them, working together to problem solve, and then developing an action plan with the patient. The last one I want to mention is reassurance. For those who have been on inpatient psychiatry units, there is often, due to acuity, due to individual patient level of agitation, there are major incidences that occur where a patient may require being restrained or secluded. There can be yelling and screaming and a lot of distress that then are experienced by our other patients. So when we have a major incident like that, we need to think beyond the individual patient who's being cared for, but also making a connection with all the other patients. How are you doing? I want you to know that the unit is safe. Can I do anything for you right now? Because this is potentially traumatizing for them. So that's some examples of the interventions utilized. We also worked with DPAC in developing a family pamphlet that would kind of provide an introduction to Safe Words model, the concepts, and the interventions. So we had it endorsed by DPAC and worked with the marketing department to develop this brochure. So this is just a very brief outline of what happened. We had a task force that was established, representative of psychiatric nursing, activities therapist, and psychology. We started that in the fall of 2020. We also received a small grant from the Department of Psychiatry to help support training materials and the calm down methods. In the winter, we developed a Train the Trainers program to help. We ended up having 6 trainers because we knew we were going to be moving many, many people through this program. Following that spring through the winter of 2021, we offered 4-hour training sessions with activities and nursing and crisis specialists, utilizing a multitude of resources that are available on the Safe Words website and also literature. In the spring, we also identified champions. Unit-based champions are really important to help own the unit or own the program at the unit level and to be a resource for other staff in developing their skill set with the interventions. Later in the winter, we integrated it into our psychiatric nursing orientation so that we could continue to offer it and also to have it not be a separate entity, but just part of what psychiatric nursing needs to be trained in to provide good and safe care. Then we had our challenges. We had the pandemic. We had a severe nursing crisis, staffing issues, turnover, a high level of acuity. So I would say we've lost approximately 50% of the people that were trained. We originally trained 160. Once we moved it to orientation, we trained an additional 60. So we are in the process of really strengthening the champion team and re-implementing on all the units. Some of the evaluative measures that we are doing is one, the educational summer or a survey that we provide and is completed by all participants following the Safe Words model training. But we'll also be looking at pre-post measures around restraints, seclusion, DPS assist, assaults, and staff perceptions of the impact of Safe Words training. So that's very quick wrap on Safe Words. The other one I want to talk for a few minutes about is the development and implementation of a psychiatric mental health nursing residency. The reason this says it's unique because this is very, very new ground for psychiatric nursing, specifically as a specialty to develop a residency program for novice psychiatric nurses. It'll help, what we find, it helps supports professional growth, confidence, critical thinking, teamwork, self-awareness, in a hope that it promotes a commitment to our practice, to our department, and also retention. So we did a literature review. Turnover was a major contributor to current nursing shortage, that training and skill development was essential. If you think about the nursing schools, and I would imagine probably in medicine as well, that during the pandemic, significant reduction in clinical opportunities. So we're bringing in nurses who have very, very minimal experience in psychiatry. So we really want to help build their skill set and knowledge base. Right now, the University of Rochester is applying for accreditation through the American Nurses Critical Care Association to be a transition to practice program. So we offer already, I think it's for the past 2.5 years, nurse residency programs that are hospital-wide. But the feedback we've been receiving from our new staff is that it doesn't help connect the dots in psychiatry. And we really needed to provide a more unique, comprehensive opportunity for our psychiatric nurses. So we received full endorsement, and I will add the statement, I want us to have a residency program. That was made by Courtney Blackwood. And hence, Heather and I moved very quickly in establishing this. So literature review, presenting to the leadership team what our learning outcomes are. We had a retreat to review the literature and develop the curriculum. And we also incorporated the PMHN Scope and Standards of Practice, which was established by the American Psychiatric Nursing Association, the International Society of Psychiatric Nursing, and the American Nurses Association. So implementation over the course, we're now in our 3rd cohort, that we've developed a binder that helps with their 6 sessions. Each session has a very specific focus, learning outcomes. We engage in many different interactive learning experiences, including unfolding case studies, self-reflective exercises. We had several expert consults come and talk with the staff, as well as provide further evidence-based practice literature. So topics from fighting stigma, equity and inclusion, responding to ethical challenges, interdisciplinary collaboration, communication, self-reflective practice, conflict management, psychopharmacology, self-care and mindfulness to trauma-informed care are examples of the topics over a course of 6 months that we incorporated into the residency program. So I'm just going to share a couple of quick, do I have a minute? Okay. Couple of quick examples. So this is example from session 2, and it's looking at a complex patient case, and then exploring different dimension of how we provide care for that patient. So things like what clinical information or orders are priorities in providing safe care to this patient. How would you document responses? Because we know that documentation is a challenge, and that we need to emphasize further the importance of clear, concise documentation. What are strategies you use to build a trusting relationship? Working with patients in their acute psychiatric illness can be extremely challenging, so needing to develop more specialized skills in that arena. Use of PO, PRN, or PRM medications proactively, and the importance of a debriefing process, not only with the staff team, but also with the patient. Another example is use of videos to help generate conversation around stigma, looking at the importance of milieu engagement, which has been a challenge at some time for our staff, that they get very afraid with so much acuity out on the unit, and how do we help support them so they feel safer to be more engaged in the milieu? So those are a couple of examples. And then also the importance of ethics. Working in psychiatry, as you know, can be challenging to our ethics, and that talking about things like use of restraints, having a consultant come from bioethics, discussing moral distress, or additional areas that we thought were important to address. And this was so fun, and I hope if you have an opportunity, you can do it, which Heather utilizes, which is a Jeopardy game. And we'd look at psychopharmacology, psychiatric illness, and have this really fun interactive team kind of experience. And then they got coffee, little coupons. We do have a pre and post. There is a psychiatric mental health nursing self-assessment and interpersonal goals that we work with staff before, and they provided after. Also, during one of the sessions, professional quality of life scale to specifically look at areas of self-care, areas of satisfaction, compassion, etc. And then we have a narrative evaluation asking 3 distinct questions regarding their experience with the residency program at the end. So I thought some of these were interesting, things that they've identified, that they've learned or strengthened their skills around. May it be being able to personally identify how they connect to a patient's experience, being able to talk about biases that may be prevalent or present in treating certain patients, how to gain advice and support from more experienced psych nurses, how to not feel so alone. Sometimes with this high acuity, staff can feel very much isolated from each other. So how do you break into that and develop more of a team supportive environment? Adding confidence, having staff from other units come together. Sometimes on the inpatient program, things are very siloed per unit. So this was a way to try to make cross kind of relationships with people. And then just thinking it's good. So that's it. Thank you.
It's my turn again. So we talked about our CPAP simulation experience, which was very specific to an area in psychiatry. And we talked about our safe wards, the concept or model of safe wards, and what that looks like across the department from an interdisciplinary perspective, and what everyone's role in that program, what that looked like. And then we talked about our residency program, which is very specific to our psych nurses, knowing that we need to increase competence in their skill set, and also knowing that we need to retain them. Now I'm going to talk a little bit about our values and in our culture. So we have very specific education that we put out, but now looking at nursing practice from a leadership perspective, do we offer a safe, welcoming, and supportive culture for each other and for the patients that we take care of? We want to be able to do that, but when we're looking at some of our data, I think we question a little bit of that. We question health disparities across not our department or not even our institution as a whole, but across the country, right? We could pick anything and find a health disparity. We can pick maternal health and recognize or know that Black women have a 4 times higher mortality rate than others. We can pick anything and find some type of health disparity. So when we're looking at our own department and we're looking at disparity and we're thinking about how we're treating our patients and how we're treating each other, we looked at restraints. And we decided to go through some of our restraint data, and we saw that we do have somewhat of an inequity in that some of our patients are restrained at a higher rate than others. So when we know we have a disparity in our own area, what do we do about it from a leadership perspective, right? How do we talk about it? How do we data share? How do we make a difference? Because we can talk about our equity and anti-racism action plan, right? This is the hospitals. We have one in psychiatry that mirrors this with very specific goals in mind. But from my place as the nursing director, I'm thinking to myself, okay, how can we make a difference? Well, one, we got to talk about it with each other, right? We have to recognize it, and we have to be okay talking about it, and that's how we come up with action planning. So what we did is we looked at our data from 2018 to 2021 at the time, and just a couple weeks ago, we were able to look at our 2022 data, and then we reviewed our equity and anti-racism action plan again, and we said, okay, we know that we need to build, that's a pillar, and we know that we need to nurture, that's another pillar. What education or what can we put in place to impact the way we care for our patients? So we brought in Kwasi Bodhi, who's the director of culturally responsive management, and we met with him and we came up with a survey. And we really wanted to look at all nursing leadership across the department. So not division specific, but all of our nurses that work here in the Department of Psychiatry, and look at what's their experience. And I know this is a very busy slide and I don't expect you to read it all, but the gist of it is we wanted to see what everyone's experience was with each other, with patients, with addressing patient-to-patient concerns. What is anti-racism? What does that mean? What does it mean to be an inclusive leader? Have you experienced microaggressions or witnessed microaggressions while at work? And what does it mean to be an ally? Can we be an ally to each other? Can we be an ally to patients? Do we feel comfortable doing that? So we sent out this survey and we got, or received a lot of great feedback, and we realized that this is a problem and we need to find ways to address it. And we also know that putting out didactic education to a group of staff is not always the best way to do it. So we had to think of something different. How do we put small groups together and really conceptualize, one, what are we working on? What are our goals? Where do we want to be? What do we want our impact to be? And how do we understand that it's so much more than a clinical presentation, right? Patients are coming to us, staff are coming to us with all of these, with their full selves, I guess I'll just put it that way. And we really need to look at what our climate is for equity and inclusion. What's our practice? So to be an inclusive leader, we looked at the adaptive leadership framework. So this is the framework that we used to apply to learning how to become an inclusive leader. And this is a definition that I really liked. I think it's great to acknowledge that, one, there's no known subject matter, right, to use in the moment, or no known policy to use in the moment when you're witnessing, say, for example, a microaggression. But an adaptive leader is, one, able to recognize the problem, right? They see it. And then what do you do next? Well, you have to be able to talk about it, and you have to be able to bring your colleagues in, and you have to be able to bring a group of people together to come up with solution-focused process, right? And if we're not able to do that, we're not going to be able to address the problem. So we need to find a way to mobilize people together to tackle some of these tough challenges. And what does that look like? Well, we have to be transparent with each other. We have to talk about emotional intelligence, right? Organizational justice, development, character. And we have to be able to work through some of these tough problems together and have a space to do that safely. And that is what my goal was with creating this adaptive leadership series. It was a 4-part series. Each session was an hour and a half long, and our entire Department of Nursing Leadership went through it. The most important piece of this when reviewing adaptive leadership, what it means, what it looks like, was the application to case studies. So we chose clinical scenarios from our ED, from our inpatient areas, from our ambulatory areas. We worked through the clinical problem at hand, but then we applied the adaptive leadership framework to the clinical situation. So what is this patient coming into the hospital with that we may not know about? What is their experience or relationship with healthcare? What's their experience or relationship with DPS? How could you apply the adaptive leadership approach in this situation? And then, is there a safe space that you can bring this information back to a leadership team about and talk about it? And that's one of the reasons we have these scheduled debriefings on our inpatient unit, so we're able to talk about some of these situations that come up with our patients. The last session of this series, session 4, was really looking at our group work. So we came together and we said, okay, so we learned all about anticipation and articulations and adaptation and accountability and awareness. Okay, we did all of those things, but how do we actually apply this? And I'll share with you the results of our survey, but what we saw is a lot of our staff weren't comfortable in applying some of this to clinical situations that made them uncomfortable. So we split up into 3 groups, and we tried to have a mix of ED, inpatient, and ambulatory areas together and work through not just clinical situations, but maybe situations with staff on staff, microaggressions, or staff to patient or patient to staff microaggressions, or maybe not micro, maybe they were macroaggressions, and we need that safe space to talk about it and how we're going to make a difference in that type of care. So we sent out a pre-survey, which I shared some of it, and I pieced some of the post-survey response data together, but you can see 4 and 5, 4 is strongly agree, or I'm sorry, 4 is agree, 5 is strongly agree, but after this series of education, our staff were more knowledgeable in the adaptive leadership framework, and they felt more confident in being able to apply it to both their leadership and clinical roles. What did stand out to us in this survey was the last one that has 7 neutrals. So we know that they were neutral, or maybe even, I would say, uncomfortable with being able to, or feeling confident in addressing concerns that had to do with anti-racist clinical practice with colleagues and staff. So they felt more comfortable addressing it patient to patient, but not comfortable addressing both colleagues and staff. So the essence of that education was really to bring people together, to have a space to talk about what's happening in our work environment and figuring out ways to address it, understand it, recognizing what our own biases are, and feeling safe to talk about it, because if we don't recognize it, we're not going to be able to change our care. So when I think about psychiatric nursing and I think about the direction that we're headed, we have to find a way to provide health equity across all of healthcare, very specific to our own department. We have a lot of opportunity. We have a lot of staff that are engaged and that want to make a difference. They want information. They want to know. They're hungry for this type of education. So this is a great environment, I would say, to bring more educational initiatives forth in learning how we can provide equitable care. And from a nursing practice perspective, I'm really proud of my team and the work that we've done, because I do think that nursing, we engage with all patients across the system, and we have the opportunity to really be the driving force to end disparity. So thank you for this time to share some of the nursing-led initiatives we've done across the department.
Great, thank you to our presenters. As you can tell, there was so much time and effort, dedication, commitment that was just very briefly described, but so much coordination, collaboration, and really trying to improve how we care for some very acute patients, how we support each other, how we communicate, and all of the educational efforts that this team and a broader team, many more that were not able to be here. I do have a couple of questions that came through some of our virtual attendees. One is from Dr. Goldstein. What do you think was the major behavior change in staff behavior that resulted from the training programs?
Can you hear me okay? Oh, sorry. I would think if I think about just one of the educational initiatives, so the CPEP simulation experience, I think the behavior is learning how to talk to each other. I think that a lot of decisions during crisis are made independently, and going through that training and recognizing that you have to have the foundation of teamwork to really make decisions together. And we put a lot of work into role clarity. And I think that made a difference in some of our restraint numbers, because we were working together a lot better than we had been previously, and roles were more clearly defined in managing behavioral crisis.
Great, thank you. Next question is from Dr. Kane. So training impact often fades. Was the reduction sustained throughout 2022?
We have had an overall reduction in restraints across the inpatient side in 2022. We actually have brought down our restraint number.
Probably by at least 40%.
Yeah.
Comparing 2021 to 2022.
Yeah.
However, seclusion is another story. We have not seen a reduction in that, so that continues to need some of our attention. Just so you're aware, we do have a high-risk work group that meets regularly, and one of the specific areas that we've been addressing is the seclusion restraint. As some of you may have read, there was a DNC article not that long ago, a few weeks ago, that compared our facility to others in the community, and we were high, especially in seclusion, both seclusion and restraint, but especially seclusion was quite high. So that is an area that we continue to work on. Now, you've seen a lot of great work already here that's been highlighted, but it's, it doesn't reflect all of the efforts, and there's so many different ways that we have been working to address this. And so this was a way to highlight some of the educational efforts and training efforts, especially from our nursing group that has really taken the lead on this. But there is more to come. And also just wanted to let you all know that we are increasingly involving our residency education leadership as well as residents. And I just recently met with a group that are very much interested in our efforts to reduce seclusion and restraints, and starting to talk about a QI project and how we can expand that to a interprofessional group, and how we can access other resources within the medical center to help us to move these efforts forward. We also have an invitation out for a resident representative on our high-risk work group. So again, there's more and more that we could talk about, but just to let people know that this is an ongoing process. And also, we do have a full-time psychologist who works on our inpatient units and has also been very much interested in working and supporting our patients and engagement, and also supporting our teams, really looking at other efforts to reduce escalating behaviors, also improving patient engagement, and thinking about our therapeutic interventions such as activities therapy, and how we can be more robust in supporting those efforts to, again, to complement all these other efforts that are already ongoing. Let's see. Any other questions for our live audience? Oh, yes.
Hello, can you hear me? Oh, now it's on. Okay, good. Dr. King had asked one of my questions, which was the dosing, essentially, of this, especially in the time of a lot of turnover and so forth, which is really very difficult. One of the questions I had then is, in the moment, when something is starting to happen on the unit, what is the sort of the team structure at that point? Who takes charge? Who runs it? You know, for example, in a code, it's pretty clear ahead of time who's going to run that and how the different duties can be passed down. And so how is that then developed, and that sort of information then spread across people, so we don't end up with a situation of too many cooks in the kitchen or whatever? And I'm not saying that happens, but I'm just curious about that.
It's typically our charge nurse that takes the lead in those situations. But, you know, one of the things that we have been working on, especially in CPAP, is involving our physicians. So if there is a crisis occurring in CPAP, we were not previously engaging with our physician group in CPAP. Nursing was more managing it and then letting the physicians know afterward, but we're really trying to create a more team-based approach in bringing our psychiatrist into it or resident into it earlier than we had been in the past. And also having our crisis specialist who's stationed in CPAP come over, if it's the adult side, and really being a part of that team too. So I think it's bringing in the right people sooner than what we had previously been doing, but typically it's the charge nurse that does that coordination.
In a given moment, is a quick decision made by those two or maybe three people saying, and then organizing folks to respond in a way. Yeah.
Yes, and the other piece to that I think is really important is that we really focused with that education on the concept of pausing. So if we're bringing DPS into the situation for additional help, there's a pause, and we need to talk about it and talk about what is our plan, if this, then that, versus everyone going into the situation and really not having an idea of what the outcome will be. So it's the concept of pausing and talking through the situation before responding.
So
I'd
just
like
so
to add-
people know that in CPEP, we do have a DPS officer who is stationed, but not in the milieu, but within the nursing station area. Also, you've heard about crisis specialists. So this is a team that over the last year and a half or so that we've been able to hire into crisis therapists. More recently, they've all been trained in CPI, crisis prevention and intervention training, to really support patients, engaging patients, working with them, de-escalation, but also supporting the teams. So pretty much 24/7, we have at least one, if not two, assigned in our CPEP. We are trying to expand the team so that we also will have availability of crisis specialists on our acute inpatient units also 24/7. Currently on the inpatient units, it's more days and evenings, but not consistently overnights that the crisis specialists are available. But they've been very helpful in terms of trying to prevent the escalation that might lead to seclusion and restraints, and also helpful as we are bringing people out of seclusion and restraints and working with them within the milieu so that we can also prevent another episode.
I
Nancy?
just wanted to add that another theme that came out from all the debriefing is the issue of role clarity and a real lack of what does a social worker do? What does a doc do? What does whoever else do to try to help contain the situation and reduce potential risk? So really looking at more clearly establishing what each discipline's role is, and also looking at this like you have medical codes, these are our behavioral codes. Right? And so we need very clear established roles for all members to know what they need to do so we're not becoming overly reactive in the situation and creating chaos.
Any other questions?
You know, I'll ask the question later. I think it's already time, but just want to congratulate our psychiatric nursing leadership for doing such a wonderful, interprofessional, innovative work. Those are the two keywords related to our education mission, and this represents the best of the best. So I just want to congratulate you. And Department of Psychiatry is very much looking for this type of projects to support. So please keep brainstorming and find a way to continue them because sometimes this innovative work happens to be just one-time event, and that's what we really want to avoid, and do it recurrently and do it repeatedly. So
Thank you.
Great, thank you. Thank you very much.
Thank you.
Thanks.